Good afternoon to all. I'm Nicola Magrini, the head of the agency here in Italy, and I'm very happy today to introduce this international seminar with fantastic colleagues and friends that will give this international seminar in the spirit of remembering a great friend and researcher, Alessandro Liberati, that inspired many discussions and also the meeting among us. The title is a long one, with the idea of considering together the role of systematic reviews in the decision-making process of the agencies that usually regulate the introduction of new drugs based on single studies or on the individual analysis of each study. To think about also patient engagement and patient involvement in both in the design of the study, in considering what are the relevant outcomes, all dimensions that were also considered by the great method and methodology that some of the speakers have contributed to develop, and that also Alessandro took part of. I have a few slides also to remember Alessandro Liberati. The next one, please. We met a few years before this nice picture, 1994, when Alessandro invited Dave Sackett, Kay Dickerson to Mario Negri Institute for launching the Italian Cochrane Center and one of the many seminars on the role of systematic review, on the role of consistency, of inconsistency of available evidence, and on many other topics that we are going to review today. Next, please. Kay Dickerson, a few years later, contributed with this nice editorial together with Lisa Barrow on defining evidence-based medicine, on which we ran many courses and several masters, also at the University of Modena, as one of the 10 or 15 medical milestones of last century, together with the invention of antibiotics or medical imaging or anesthesia, vaccines. They proposed also evidence-based medicine. I think being Kay Dickerson in that picture, it was for me good to remember her in this way. Today, next slide please, we are going to review three main topics only of the many that you can see in gray that we will not discuss today, that were the object of many papers and discussions and interaction with the research community. Today we mostly discuss the role of systematic review and or the risk of publication bias or outcome reporting bias, not only in the literature but for the decision-making process of regulatory bodies. How relevant is the patient or citizens' involvement or information versus persuasion? I took this beautiful opposition from Andy Oxman title. And also in general, estimating and communicating risks and benefits and the uncertainties around them is certainly are certainly three important topics that we, Alessandro, for 20 years try to identify as research priorities too. Next, just to reflect and smile. Next slide, please. I would like to share a couple of publication bias that we found and sometimes share. of published trial. Please, next. This Dementia Trial published, please, next. This Dementia Trial published by the manufacturer of galantamine, comparing galantamine and donepezil to drug modestly effective or poorly effective against Alzheimer's disease, showed these results. Next, please. With galantamine slightly favoring donepezil in this non-inferiority trial, and in one of the several outcomes examined, it was slightly superior in terms of patients responding to therapy. Next, please. In this other donepezil against galantamine, the opposite, which means the same, supported by Pfizer, the results were the one we show. Next, please. With the donepezil, now in green, being superior on physicians' satisfaction, that is not really a patient outcome, is the physician satisfied. And unless it is the green prevailing, I think this could be an example of outcome reporting bias, showing how cherry picking among possible outcomes on studies that perform multiple examination can drive improper conclusion. Next, please. This paper that, again, Lisa Barrow and Kay Dickerson conducted a few years ago, so to review a Cochrane review that's probably biased due to publication bias, showed this marvelous graph, in my view. Next, please, where outcomes were changing according to whether they were the published one that were changed from the original protocol, and also in order to become significant. And this happened in a certain number of trials, and led the Cochrane group to review based also on a careful analysis of how much in the publication were respected the original outcomes in the protocol. Next, please. On patient involvement and persuasion, please. Next. How do we communicate risks and benefit, and the role of reliable evidence has been a topic that for many years at every Cochrane meeting or with some of the guests Alessandro was able to invite, as he has been a tremendous socializer among busy researchers. We had the pleasure several times to have Drummond Rennie with us. Next slide. And this was our favorite slide that Drummond was carefully reading every time to reflect on the quality of medical publishing. Probably to read again, there seems to be no study too fragmented, no hypothesis too trivial, no literature citation too biased, too egotistical, design too warped, methodology too bungled, presentation too inaccurate, obscure, contradictory, analysis too self-serving, an argument too circular, conclusion too trifling, or unjustified grammar, syntax too offensive for a paper to end up in print. So that's how we started our evidence-based medicine course and workshop that were organized by mostly Alessandro in Modena, Milan, and other places, not only in Italy. Next, please. But the research, let me say business for shortness, is a very serious thing, and we all think so. And when this paper on Ebola was published in the New England, showing there was the clear possibility to perform high-quality randomized trial during emergency with high-cost medicines or with sophisticated medicines such as monoclonal. Please, next. Showing that some of the available medicines are better than others. Next, please. It has been an immense contribution to the idea Alessandro has always brought forward that there's no circumstance in which research cannot be applied, cannot be useful, and cannot be an improvement on the actual patient condition. Next. just to underscore what these incredible researchers performed, we encountered numerous challenges in the performance of this trial. It was conducted in a region of DRC, Democratic Republic of Congo, in which there is regional violence, mistrust of government, mistrust of Ebola response, unstable electrical power grid, transplantation difficulties, and a history of high morbidity from other infectious diseases. And they performed it. And the conclusion, actually, please next, show that it is possible to conduct scientifically rigorous and ethically sound research during an outbreak, even in a conflict zone. I think it's a lesson we learned also in Italy when there were discussions whether or not standard patient in our NHS should and could be included in clinical trials without interference with clinical activity. This has been a long-standing discussion. I think this trial shows the importance, and even nowadays during COVID-19. Next, very rapidly, and then we move on. That were the conditions in which these trials were conducted. What's next, please, rapidly? On communicating risks and benefits and uncertainties, because uncertainties or confidence interval are not very well known, and we often portray as exact estimates our rapid reading of the point estimate of the study. Next. Today, I was happy to receive from a friend this New England Journal of Medicine commentary just published, and I think is a lucky event that today the New England publishes this on whether to communicate to patients the conflict of interest of the researcher or the doctor who is curing him or her. And this is a step forward on an area, conflict of interest, that has always been of tremendous interest of all of us. Now I can say research community, Cochrane friends, and certainly also the regulatory agency. I move to my conclusion, and next, as today, please next, Richard Smith, who was invited to join and maybe to chair today, was not able to come as he's traveling in South America. Let me conclude with one box he put in one of his last paper in the BMJ. Next, as the world changes, what will persist, which I think is also largely the legacy, to me at least, of what Alessandro taught me and us all. What will remain? Clear ethical values, I hope. Being clear about the purpose of your organization, certainly important and easily forgotten. Putting patient first, constantly trying to improve, basing what we do on evidence, a positive leadership role, and educational learning. Thank to all the more than 1,300 colleagues and researchers that have joined us today. It's a real success. It means this kind of seminars are of interest. And now leave the floor to Andy Oxman, a super researcher in this field of evidence-based medicine, a founder member of the GREAT group, and an exceptional researcher in global health and public health, also engaged in very interesting recently project in Africa and in Uganda in particular. He has asked only to be defined as the research director of the Center for Epidemic Interventions and Research at the Norwegian Institute of Public Health. Please, Andy, the floor is yours. Thanks a lot for having agreed to be here today.
Thanks, Nicola. So I first started working with Alessandro about 30 years ago in the Cochrane collaboration. And about 20 years ago, we started working together in the GRADE working group. And some of what I have to say is going to build on the work that we did together. One of the last things we did together was to publish an article in the BMJ Christmas issue, which was a field guide to experts. And I mention that here because one thing that experts often do is try to persuade people about what they should or shouldn't do. And that's the focus of what I'm going to talk about today. So I'm going to talk about health communication, particularly health communication by health authorities, both in the context of public health emergencies, particularly the COVID pandemic, and conflicts between whether the aim is to inform or persuade people. Next. And I just want to acknowledge my colleagues who are co-authors of this work. I won't read off their names, but obviously this isn't something that was done by me alone. Next. So a problem that accompanied the pandemic was what has been referred to as an infodemic, overabundance of information, both bad and good information, that's made it very hard both for the public to know what to believe and for health authorities to communicate. It's not necessarily new. There's been an overflow of information all along, but it's been exacerbated during the pandemic. Next. And part of what that's brought out, certainly for us where I work, is a tension or a conflict between whether health information that we put out, that health authorities put out, whether the aim is to inform people, for example, about the pros and cons of wearing face masks, or to persuade them, for example, to wear face masks by giving them messages that we believe will persuade them to do that. Next. So there's potential conflicts between what you'll do if you're trying to inform people versus if you're trying to persuade them. Next. And I'll talk about that first, then I'll talk about the role of spin and using changing people's behavior through spin. Next. And then I'll talk a bit about the ethics of persuasion. Next. Communication in the context of public health emergencies. Next. And lastly, some principles that may be helpful to guide decisions by health authorities about whether they should aim to persuade people or not. Next. So potential conflicts. Next. Clearly, there's been lots of restrictions. You've experienced those in Italy. We've experienced those here in Norway. People all over the world have experienced many different measures that have been implemented to control the pandemic. And there's been a trade-off all along between the health impacts and democratic rights of people to decide themselves what they want to do or don't want to do. During the pandemic, governments and health authorities have often attempted to persuade people to follow restrictive measures, sometimes mandated it. And on average, it's important to, or it's worth noting that democratic governments were often slower than autocratic ones to implement and enforce restrictive measures. And that has to do with the balance between democracy and doing what people believe is good for the public. Public messaging about recommendations and policies intended to control the spread of COVID-19, they've often changed. Next. And communication between the scientific community and policymakers hasn't always been candidly shared with the public. Next. In addition, researchers eager to promote the value of their work often have hyped it using spin. Next. And as a result, COVID-19 related communications by policymakers, health authorities, researchers, and others can feel untruthful, inconsistent, and opportunistically shared. Next. So on the one hand, more candid communication could potentially make policy changes seem less arbitrary, could help to preserve trust in the organizations or authorities who are communicating the information, and could increase support for and willingness to participate in future research. Next. On the other hand, more candid communication might reduce the perception of effectiveness if people recognize there's more uncertainty or the effects are smaller than they might assume. And that in turn could reduce compliance with recommendations and policies. Next. So there's a potential dilemma here. If the goal is to enable informed choices, to help people make good choices by informing them, then what you're going to want to do is communicate information that clearly presents what is known about the pros and cons of an intervention or different options. But this might reduce compliance with the recommendations or support for the policies. And to the extent that an intervention is effective, it would result in worse health outcomes. It might also increase inequities if some population groups are less likely to have access to that information, to understand it, or less able to use it to make informed choices. Next. Whereas if the goal is to maximize compliance, communicate, then what you're going to want to do is communicate information that's designed to persuade people of the benefits of doing what you think they should do. But that's going to limit people's ability to make informed choices, and it may erode public trust in the authorities. And it also may make it more difficult to conduct needed research. Next. And of course, this has happened a lot during the pandemic, but it's not just a problem during pandemics. It's also a problem in the context of health promotion. For example, campaigns targeted at vaccination, not just vaccination for COVID, smoking, drug abuse, unsafe sex, obesity, meat consumption, screening. And it also is sometimes relevant in clinical practice, for example, in relationship to communication targeted at adherence with medication or treatment plans, or for preventive medicine. Next. So I'm going to talk a little bit about spin before I go on to outline some of the ethical issues here. Next. So one way to persuade people is to use spin. In other words, to emphasize the advantages of the desired option and ignore, downplay disadvantages and uncertainty. And it can be done intentionally or unintentionally, and it's found pretty much everywhere. It's in the scientific literature. Researchers do it. It's found in press releases, both by universities and by journals. It's found in news reports. It's found in advertisements, in public health messages, in health service messages, government messages, and in industry messages as well. For example, tobacco or sugar industry, as well as the pharmaceutical industry. Next. And there are a number of ways in which this can be done. It can be done by focusing on the problem, by emphasizing or exaggerating the seriousness of the problem and ignoring or downplaying uncertainty about the problem. It can be done by exaggerating or emphasizing the benefits of behaving in a certain way while ignoring or downplaying the harms or undesirable effects of behaving in a certain way. It can be done in relationship to information about costs by ignoring or downplaying the costs and emphasizing or exaggerating the savings of behaving in a certain way. And it can be done in relationship to the alternatives to the desired option or way that you want people to behave. For example, misinforming or leaving out information about relevant alternatives. Next. And of course, there are other persuasive strategies that can be used that aren't spin. You can use words or hyperbolic language without presenting numbers. You can present risk ratios for benefits and absolute effects for harms. You can arouse fear, for example, by leaving out the denominator or using a larger denominator or a longer time period to increase the magnitude, the perceived magnitude of the risk. You can use narratives. You can use expert sources to support claims. A number of ways in which health authorities and others try to persuade people. Next. Now, when there is compelling evidence that the advantages far outweigh the disadvantages, the difference is likely to be smaller between information that's designed to persuade and information that's designed to inform. So, for example, if you think about vaccines for measles, mumps, and rubella, there is clear the advantages clearly outweigh the disadvantages. Most people would agree with that. Parents want balanced information about the benefits and harms of childhood vaccination, and providing them with clear, concise, evidence-based information could both build trust and persuade them to consider the evidence when they're making decisions. And there's some evidence to support that. Next. On the other hand, when the benefits and harms are closely balanced, the difference between or the size of the benefits doesn't greatly outweigh the disadvantages, then it's more likely that information designed to persuade is going to differ substantially from information that's designed to inform. So, for example, it's not clear that the advantages outweigh the disadvantages of breast cancer screening. There's been a number of different guidelines that have come up with different recommendations about this for different age groups. And communication to increase uptake then of screening mammography differs substantially from information designed to enable informed decisions about breast cancer screening. Next. So I'll say a little bit about the ethics of persuasion before we have a break for some discussion, and focus particularly on issues related to autonomy, beneficence, that it is doing good, and non-malfeasance, that it is not doing harm. Next. So bioethicists tend to, when they talk about persuasion, use three categories. Persuasion, which they define as influence by reason or argument. Coercion, which they define as influence by irresistible threats. And manipulation, which is everything in between. And there's debate amongst bioethicists then about that middle category in particular, which is very broad and includes both influence that's based on behavioral science, which may be perfectly ethical if there's a good basis for choosing to do that. But it also includes dishonest or unfair influence, such as using spin. And if you think before you get to persuasion, the continuum continues to the left there. So you may simply want to inform people, that is, provide options and the pros and cons of each option. You may want to make a recommendation, suggest or advise a particular decision, but leave it up to individuals to make those choices. And so examples of each of these would be to summarize what's known or not known about the advantages and disadvantages of wearing different types of face masks in different circumstances. That would be informing. Recommending would be recommending face masks based on what is known. Persuasion would be encouraging people to wear face masks based on what's known, influencing decisions by reason and argument. And then we begin to move into the area of nudging, which would be a type of behavioral science where you might nudge people to wear face masks using messages such as protect your loved ones, or comparing face masks to helmets and seatbelts, and more unethical manipulation, exaggerating the effectiveness of face masks or ignoring or strongly downplaying undesirable effects and uncertainty, spin, and on the far extreme, threatening people by communicating, penalized, having a mandate, and penalizing people who don't comply with the mandate. Next. So with respect to autonomy, information that's designed to inform people is clearly based on the basic respect for people's right to autonomy, to make their own choices. Some autonomous choices that people make entail risks, such as riding a motorcycle, but in most societies, we accept that people are going to choose to take risks, and we don't forbid, for example, riding motorcycles. And so those sorts of choices are respected, provided they don't harm other people or create undue collective burden. It's when it begins to affect other people or create a burden on society that we begin to restrict autonomy. Next. So information designed to persuade doesn't necessarily infringe on people's autonomy, but it can if it's manipulative. Next. So, for example, spin is manipulative if it's used deliberately to influence people's choices. For example, withholding information on rare but important vaccine side effects. Next. And providing information designed to arouse fear or other emotions such as guilt can also be manipulative. For example, during the COVID-19 pandemic, informing people about the gravity of the situation, focusing on worst case scenarios. Next. So people should, of course, be told the seriousness of the situation so they can make informed choices. Next. But emphasizing the worst case scenarios can exacerbate fear, anger, anxiety, and do this unnecessarily. Next. Some people will argue that autonomy is sometimes maybe deceptive. For example, people's choices may unknowingly be shaped by their environment or by misinformation provided by actors with special interests. So, for example, the food industry puts out lots of information that shapes our beliefs and attitudes towards food, or many people's beliefs and attitudes. And so you could argue in that context, are they really making autonomous decisions? Next. In addition, people don't always rationally weigh their options and decisions. They're often affected by cognitive biases. Next. However, it's questionable that this justifies health authorities or governments acting in a similar way to manipulate information or people's emotions. Next. Beneficence. Next. So arguments for designing information to be persuasive, in contrast to arguments for information to inform people, are largely based on beneficence. And the assumption here is that the people responsible for the information know what problems should be addressed, what the goals people have, and what is best for people. They're making decisions on other people's behalf. And if these assumptions are well-founded, it may be justifiable to persuade, manipulate, or even coerce people. In other words, have mandates or restrict their ability to make choices, despite some disagreement. So, for example, seatbelt laws, traffic regulations, information to promote adherence to those are widely accepted, and they're well-founded in many countries, although not everyone agrees. Next. Non-malfeasance is an important downside or consideration of persuading people. Health information that's designed to be persuasive can be harmful. Next. And it can result in victim blaming, for example, suggesting individuals are responsible for their behavior, and if they do not behave in a desired way, they're responsible for the resulting problems. Next. And it can result in stigmatization. For example, well-intended information campaigns to reduce obesity and health consequences of obesity have contributed to blaming, shaming, and stigmatizing obese people. Next. Next. So, Nicola, I'll hand over to you for discussion before I go on.
So, first of all, many thanks. I would like to invite the audience, if they have any questions, to send them in the chat. They can. And I think you truly inspired in all of us some reflection on what we have been living in the last 2 years. If I can add just a further comment from you on influencing people and the difficult dialogue with the so-called Novaks that are a fairly heterogeneous group of people. But I found your suggestion to pay attention on the potential consequences on stigmatizing behavior or accusing people. What relevance do you think could have had also recently, as this Novaks is a global phenomenon, is very complex? What would be your further reflections, as we know there's no solution or not an easy one?
Well, I'm not going to give you an easy solution, obviously. There's, as you say, I think people who choose not to be vaccinated do it for a variety of reasons. And I think that any effort to persuade or coerce people to get vaccinated is going to have to be tailored to the subgroups of people that you're targeting. And so that means you need to know something about who you're targeting. You have to talk with them and understand their reasons for not being vaccinated, and let that guide how you're going to intervene. And it's likely to take different approaches for different subgroups of that population.
Thanks a lot. Please, Patricia.
May I give a comment? Thank you very much. Thank you very much. I found these reflections very inspiring and very timely, of course, in this pandemic period. I was also impressed as a coordinator of a technical committee at the drug agency, because although a technical committee is not supposed to inform the public, not directly at least, I realized that even the words we use to explain or to justify a decision or an opinion may become a sort of communication strategy. So this worried me quite a lot, because it's an increased responsibility. What do you believe?
Well, I'll come to that at the end of my talk, but I do in fact think that it is important for people who advise governments, people making decisions, to think about the information they communicate. I think both governments and organizations, authorities that advise government should be transparent in their decision making. And I think that both people making recommendations and people making decisions should reflect on when they're making a decision, a recommendation or a decision, whether they should be aiming to inform people or persuade them.
Mm-hmm. And also speaking in terms of the ethics of persuasion, it is a very critical issue, because in the continuum line, it is in the middle between inform and manipulate. So we should be very careful, and it is a very critical point. Thank you very much.
I think we can move on and invite again the audience and people attending to send any questions related to what we are discussing. Please, Andy.
So I'm going to say a little bit about communication in the context of public health emergencies, and then come to what we think are the principles that should guide decisions about whether we should be persuading or informing people. Next. So the extent of uncertainty and the need to respond urgently may limit the ability to use systematic and transparent processes in public health emergencies. Next. However, health authorities and governments can be prepared by having established processes for making recommendations and policy decisions. Next. They can use existing evidence to inform decisions and recommendations. Next. They can produce evidence to address important uncertainties, and that's been done far too little for public health interventions during the pandemic. And they can use evidence-informed guidance for risk communication. So there's a number of guidelines that are, at least in part, based on evidence, advising us how to communicate risk. Next. Another way that they can prepare is by fostering critical thinking. There's no way that health authorities or anybody can control all of the information out there, or fact check everything that's out there. The public needs to be able to do this. And unfortunately, these skills aren't currently being taught in schools. Public health authorities, governments can begin to foster critical thinking skills that you need to make informed judgments about when claims about what you should do or shouldn't do are well-founded and when they're not, and to reduce people's susceptibility to misinformation and help them recognize good information. And right now, many people lack those skills, and they're not being taught in schools. Next. So both persuading people and informing them are reasonable goals. And the three main factors that would lead me to want to think about persuasion are the greater the impact of doing something on others is, the more likely it is to be justified to persuade people to do something. In other words, if wearing a mask not only protects your health but protects others, that increases reasons for wanting to persuade people to do that, or vaccines or whatever. Clearly, the more sure we are about the effects of doing something, the better the grounds for persuading people. And the greater the risk, the anticipated risk, say, of pandemic or risk for disease, whatever it is, the more likely it is to be reasonable to persuade people. Next. So we've suggested 9 principles that we think should guide decisions about whether or not we should be trying to persuade people. Next. So the first is evidence, and that is to start out by looking at what's known about the potential impacts of the behaviors that you think people should perhaps adopt, as well as what's known about the potential impacts of whatever communication strategy you're thinking about using. The second is participation. Decisions should reflect the values of those affected. The messages should as well. So that means engaging the people who are going to be affected in the decisions that are being made. Fairness or equity is taking into consideration potential impacts of the message on different populations, and in particular disadvantaged populations. Transparency, I think, is critical. That is presenting the justification for whatever message is being given, being transparent about that. Precaution has come up a lot in the context of the pandemic, this principle is defined in different ways, but basically the idea is when there's a credible threat of serious harm, that acting urgently is warranted. In this case, it may warrant an urgent message. But that always needs to be coupled with the sixth principle here, proportionality, and that is the message, how strongly you're trying to persuade people or mandate that people do something should be proportionate to the level of risk. Flexibility is very important here. The message both needs to be tailored to key target audiences, and you may need to tailor different messages to different audiences and their contexts. And it also has to be modifiable as new information becomes available, which we've observed repeatedly during the pandemic. Testing has been hugely overseen during the pandemic, but it's important that once you do have an idea of what the message is, you need to test the communication to make sure that your target audiences understand it in the way that you want them to. And lastly, uncertainty. You need to identify important uncertainties about both what you think people should do and the impacts of your message about it. And when possible, those uncertainties should be addressed through research. Next. And I think those principles largely can be applied to mandates as well. That is restricting people's behavior by not recommending something but requiring that they behave in a certain way. Next. But when a behavior is mandated, messages about the mandate also can either be designed to persuade people to adhere to the mandate, or they may be designed to inform people. So you may want to inform people about what type of mask to wear, how to wear it, when to wear it, if it's cloth, how to clean it, or throwing out single-use masks. On the other hand, you may need to, even when there is a mandate, persuade people to adhere to a mandate. So the picture here is from the US, where there was a mandate, in fact, in Illinois, and a lot of people weren't complying with the mandate, and so they did do some research with their target audience, and they found what resonated and worked best with their audience was comparing wearing a mask to wearing a bicycle helmet or wearing your seatbelt, and they used that to persuade people to adhere to the mandate. Next. Next. So I'll wrap up next. So the justification for persuasive messages should always be transparent. Clear, actionable messages can stand alone, like the ones showing comparing face masks to helmets, and they can be made justifiably sometimes even when there is low certainty. Next. But persuasive messages should not distort the evidence, and it should be easy for anyone who's interested to find the justification. Next. When there are important uncertainties, they should be acknowledged. Not disclosing uncertainties distorts what's known. It inhibits research to reduce important uncertainties, and it can undermine public trust in health communication and in the institutions producing it. Next. So going back to Alessandro, the last thing that he published was an editorial in The Lancet. And he argued that people facing life-threatening illnesses have a right to expect that research into their illness will address the uncertainties that matter most to them. And unfortunately, that wasn't always the case then, and it's not always the case now. Next. And this also applies to pandemic control measures, which I talked about a bit in this talk. There are many important uncertainties that aren't being adequately addressed. This figure comes from what's called the BESI collaboration that's focused on behavioral, environmental, social, and systems interventions. And there's been thousands of drug trials registered, many of them published already. There's only been 16 trials of these other public health interventions. And there's lots of uncertainty about the benefits and harms of many of them. Next. So Alessandro argued in his editorial that a new governance strategy was needed for clinical research. And I think the same is true for research about public health interventions and policy decisions, that they need to be more inclusive and deliberative decision-making processes that involve members of the public. And on the plus side, there are a number of examples of this being done during the pandemic. The image here is from a database that's called Participedia, which includes many examples of different ways of supporting participatory democracy. The downside is these are the exceptions rather than the norm. And I think we need to put more effort into finding ways to actively engage the public in these decisions, both about what to do and about what research to do to address important uncertainties. Next. Gracias.
Thanks a lot. Thanks a lot, Andy, and I truly grateful.
Grazie, I would say, grazie. Grazie molte.
Please, Patricia, go on.
So, thank you again. I would like a comment from you on the following topic. So, COVID-related issues are something people are very fond of. So, there is a huge media coverage, and as a consequence, maybe partly as a consequence, there are so many experts giving so many different opinions. So one of the problems is that communication should be fair, transparent, not misinterpretative, but it should be also consistent. It should be also credible. Don't you agree?
I agree with everything but consistency, and that depends what you mean by consistent, because things have changed dramatically over the past 2 years, and so a consistent message would have been misleading. Things have changed, and so messages have, for good reasons, changed.
Sure.
Yeah.
I didn't mean consistent over the time, but just consistent according to different experts speaking at the same time. So the message.
Right. I don't think that's necessary or possible. Experts often disagree. They have opinions. A lot of recommendations are not, they may be based on whatever evidence there is. They're not always, sometimes they're based on different evidence, sometimes on the same, but hopefully the best available evidence. But those decisions require value judgments about what's important to people. They're very difficult judgments. I'm very glad I haven't had to make those decisions. And so that means that it's not just a question of experts being in agreement, but it means being transparent. What evidence is there that's informed our judgments, or the judgments of people making recommendations or decisions? what criteria were used to make it. So many of you will be familiar with GRADE and the use of evidence to decision frameworks. Holger maybe will say more about that, I don't know. But that's, in my mind, a very important way to make the decisions transparent to win the trust of people so they can see exactly what evidence based on what judgments have been made, what criteria have been used. So I think transparency is really critical there.
Okay, thank you. There could be a question from the audience, but I can't see it anymore. Could you please help me?
Maybe I can. I can see and I can still read. Do you think that timely systematic analysis of people's communication patterns on the web infodemiology may inform decision on how to communicate during health emergencies?
Yeah, absolutely. And I'm not by any means an expert on that, but there's a lot of very good work being done, info epidemiology, that's monitoring social communication, communication on social media, and that provides a good basis for health authorities, people trying to help people to make sense of that information, to address misinformation that's coming out, and identify that and deal with it. Absolutely.
A simple question: how would you call, or how can we call the cube you showed? Oxfam Norwegian cube, or I only knew the WHO cube on an axis, but this is very nice.
We can call it the Alessandro Liberati cube.
Great. Very nice. So maybe we can move on so that we can have some time after the second presentation. And
sure. I think quickly, it looks like there's a question about using social media for health communication, and can it be used? And I would say absolutely. I think it's really important for health authorities to be actively using social media. People get lots of information there now, and we need to learn how to do that effectively and efficiently.
Thank you, Andy. So, Patricia, please.
Yes, thank you, Nicole. I'm very pleased to be here to co-moderate this seminar, because although unfortunately I didn't know Alessandro Liberati personally, in some way is like I knew him from the memories, the affection, and the esteem of many common colleagues and friends. So I'm very pleased to have the opportunity to introduce Holger Schönemann, who's director of the Department of Health Research and Methods, Evidence and Impact of the Cochrane Canada and McMaster Grade Center. Holger is a very well-known expert in methodology of research and on the use of evidence, and so I'm very pleased to have him here. Please.
Thank you very much for having me. It's a really great pleasure, and I would like to particularly thank Nicola, obviously, for the invite. Just a quick correction: I'm not director of the department anymore, just for consistency. I finished my 2 terms, and I'm very happy about that. But this is my topic for today. So thanks for the introduction again, and it will build on I believe some of the work that we already discussed, and it is about COVID-19 guidelines for the public primarily, and I'll introduce how we've dealt with trying to catalog health recommendations about COVID-19 and what we call the e-COVID recommendation map. Next, please. These are my disclosures. I don't have any financial conflicts of interest. There has been funding, and most importantly, as I showed on the previous slide, this is really reflecting work of a large team that I will get back to. But next slide, please. I met Alessandro through the great working group that was mentioned already about 20 years ago, and this is actually from his farewell message that some of us received, and it really, as I was reading it again in preparation of for this webinar, this is a sentence that clearly stuck with me, and it is about the memory that he hopes that we would have of him, and I clearly have very fond memories. This is actually from the last time that picture was taken, around the last time that I talked to him, shortly before his passing in Madrid at the Cochrane Colloquium, and I will get back to the profound impact that Alessandro probably not knowingly had on a lot of the work that I'm still involved with. Next. So the objectives for me today are to inform about the eCOVID recommendations map, and how that type of work can be transferred to other settings, and how we can make actionable statements, that is a bigger category term for recommendations, understandable, and the work that we are doing around that. Next. Here's the link to the website. Essentially, the goal of this work is to map and to praise all COVID-19 health recommendations, so a really broad scope. And we talked a little bit about consistency of messaging. The idea about this came really from the many health recommendations that were developed early on, and understanding consistency between them, but also what was already referred to, the credibility of these type of messages that were produced by guideline producers. But much of what I will be talking about today assumes that many of the organizations actually do produce recommendations that are at least transparent and credible. And I'll talk a little bit about how, through work that Alessandro had some impact on, users can actually adapt the recommendations to their context. This work was funded by the Canadian Institutes of Health Research, and I work in Canada, obviously, and we're really grateful for their funding. Next. So the purpose of our work was to produce and provide decision makers and other stakeholders, including the public, with an easy to navigate, living, freely accessible electronic platform. Next. That includes all available trustworthy COVID-19 recommendations and allows for easy contextualization. Next. And to identify these recommendations, critically appraise them using established tools, and then make them available for contextualization and implementation by decision makers globally. Next. This builds on work done for the World Health Organization on tuberculosis recommendations. Next, and it's based on a work of an international team, a large international team, and indeed too large to mention everybody. Next. So we, in a very short period of time, there was a call for applications by the Canadian Institutes for Health Research, and I had luckily talked to colleagues from Norway at Andy's institution, and we were prepared to apply for funding, brought this large international team together with over 50 researchers, and that worked and lived in 19 countries. Next. We are providing on this tool recommendations that can be searched for. So, for instance, if you were to go and look for vaccination, you would find recommendations from any type of organization across the globe. Next. And you could look at, for instance, if you were particularly interested in Centers for Disease Control and Prevention messages or recommendations, you could filter that. So there's a whole list of filters to refine your searching if you had interest in a particular topic related to COVID-19 that was addressed by a health guideline. Next. And we used an approach that comes from evidence mapping to also map out potential gaps in health recommendations, as well as abundance, I would say. Next. This can be, for instance, for treatment and rehabilitation. Next. You find many separate topics that they're expandable to see again what type of recommendations might be available, and I refer you back to these filters on the right-hand side. And the way that we do that next, please, the way that we do that is described in this slide. So we screen published recommendations in PubMed on a daily basis. This is done in collaboration with the Health Information Research Unit at McMaster University. We screen the gray literature, do that bi-monthly or monthly, depending on the organization of important organizations. We screen websites using standard techniques, and obviously use personal contacts and partners, and we'll continue to do that until at least June 2022, but hopefully longer. Next, we also involve a international network using the Cochrane Task Exchange of citizens in this work, and I will come back to that in just a little bit in terms of how we actually do that. Next. So just in terms of an update, so far on this resource, we have over 4,000 recommendations from different guideline producers, and you can just imagine talking about consistency, that there is a lot of inconsistency between recommendation producers. And next. And so one way for us to understand inconsistencies and to also present information, following up on what Dr. Oxman said, present information in a way that people or users of these recommendations can understand them, is to provide background information to individual recommendations. So we abstract information, we critically appraise it. You see there these agreed 2 scores, which is an instrument to evaluate the credibility of health guidelines, including looking, for instance, for editorial independence or conflicts of interest that was described, and evaluate whether or not that was appropriately dealt with or at least documented appropriately. And here's a recommendation that basically talks about whether or not people with risk factors and COVID-19 should be using home oxygen monitoring. And there is a conditional recommendation that was made by the World Health Organization based on very low certainty of the evidence. But there are some important features there on the right that are surrounded by this red rectangle. Next, please. Including information that describes how evidence was used to come to a recommendation, the ETD, evidence to decision frameworks that we briefly touched upon. So for each of the recommendations, we either use what the guideline producers described, or we extract the information and categorize it into what is called the evidence to decision criteria. And the important reminder here is, Andy may correct me if I'm wrong, but you've reminded me that this producing a transparent way of describing recommendations actually goes back to a suggestion that came out of a great meeting in Lyon, in which Alessandro suggested that we should be transparent about the decision making, not only about rating the certainty of the evidence. So this work has actually tremendously influenced a lot of what we're doing today. Next. So we extract information that relates to the evidence to decision criteria. This is a publication that came out of a European Union supported or Commission supported grant that Andy co-led, and that goes back to these evidence to decision frameworks and describes the criteria or important criteria that may influence a decision and a recommendation. So for instance, the benefits and harms of an intervention, issues around cost, issues around values related to the outcomes that the intervention might affect, acceptability, feasibility, and so on. I assume that much of the audience will be familiar with GRADE and will not spend too much time on this. Next, please. And these criteria then influence different types of decisions. And this is actually quite important as we're talking about our recommendation map, that the information, if extracted appropriately, might be supporting decision-making in different contexts, including decisions, for instance, about coverage, or decisions in the context of public health decision-making that may be then utilized for individual decision-making. These are the evidence to decision criteria. Next. This information, as I said, is abstracted, and transparency means that we are also abstracting any type of numerical or statistical information in so-called summary of findings tables or evidence profiles that are part of the recommendation map next. And this type of information, I talked about this, and I think this also relates to the international aspect and the internationality, perhaps of Alessandro's work, bringing big networks together. This information then, through the ETDs, we believe, can be utilized to adapt recommendations. And I'm just going to show you 4 very quick examples. So information from the map has been used for adaptations in South Africa, for hematology-related recommendations or prevention of thromboembolic events next. It's been used in Brazil with a lot of discussion and very difficult decision-making interference by, I would say, by policymakers that was not always evidence-based, but at the end of the day, those colleagues in Brazil used the recommendation map to make recommendations to tackle the COVID-19 pandemic next. It's been used in the Czech Republic, the evidence to decision information or extracted information to adapt recommendations for the context. So the evidence to decision frameworks allow to understand what a certain guideline group might have thought about a recommendation and utilize that information, contextualize it, ideally supported by local evidence in order to see whether or not these recommendations actually should be or are applicable to the context. And next, finally, obviously in Canada, and here's an important part of the information here is that information from the map was utilized to adapt recommendations for a certain population, and that then was fed back into the actual recommendation map. And this is the time where I take a brief break for just any questions of clarifications before I talk about communicating with the public.
Thank you. Thank you very much. I believe that having a map with evidence, you collect evidence, you appraise this evidence, you evaluate the level of certainty of the evidence, then you get the evidence in the hands of policymakers, but at the same time, you share the evidence with the public because there is also a plain language. So in the same map, there is evidence communicated to the policymakers and shared with the public, which is something also Professor Oxman said in one of his slides. We should share with the public the communication between the scientific community and the policymakers. So this map in some way can allow this.
Yes, so I will speak more about that in the second part, right? It's exactly like that. What we realized is that these messages, for the vast majority of these over 4,000 recommendations, were directed at health professionals, and that the organizations failed, I would say, that's probably the appropriate term, to spend more time on appropriately communicating these recommendations to the public, because as Dr. Oxman described, at the end of the day, the decision is, in many instances, a decision, depending on the type of recommendation, that an individual needs to make, and the individual needs to understand the information and needs to probably understand the recommendation, both in terms of the underlying certainty and the underlying strength of the recommendation. And we realized that after we had spent a lot of time developing the concepts, that this was actually not appropriately done. And our big goal right from the start was to actually communicate with the public as well. That was one of the target audiences, but we couldn't because of the way that the recommendations were actually written. And I'll talk more about these plain language versions that we're now working on in order to enhance that part of the communication to citizens.
And also adaptation to the local situation is another important tool in order to make this recommendation and this evidence usable by people all over the world. So
Yeah, and I think this is the fundamental contribution of these evidence to decision frameworks, that they allow us to lay out the criteria that make a guideline group think about either to recommend an intervention, for an intervention, or against an intervention. But as was already emphasized, this depends on context. And if the context is different, then the same evidence or similar evidence may apply, but the evidence might be interpreted differently. Or a very simple example is the burden of infection, or the rate of positivity, if we want to call it this way, may influence whether or not a mask is recommended or not. And everything depends on the baseline risk, and that type of information is contextual information that needs to be considered.
Thank you very much. Nicola, would you like to comment, or?
No, I think we can move on, and then at the end, for sure.
Okay, please.
Okay, then back to my slides, perhaps. I will just briefly go through that. So we were talking about how to possibly increase the communication with decision makers. So in the second phase of our project that really just begun, we started to think about how we can communicate in plain language to the public, and some of these recommendations, we now have 34. It's still a small number, but it also describes how complicated that is. We have actually started to use existing strategies for translating health professional directed recommendations into plain language recommendations. So some of the recommendations now have plain language versions. Next. And essentially what we do there is we provide easy-to-read summaries of published and quality-checked recommendations. These are balanced statements that include an explanation of the recommendation and what it means to the public. PLR, as we call them, are derived from leading guideline development organizations and include a link to the underlying evidence. It's based on the GIN Public Toolkit. So GIN stands for the Guidelines International Network Public Toolkit. Other types of background work that has been done in this context, and the great format of plain language recommendations. Next. This is from a quite recent publication that emphasizes some issues that were already addressed by Dr. Oxman. Information needs to be personalized, the strength of the recommendation, the credibility of the information, of the uncertainty needs to be described. But there are also many important issues around how the information is formatted and presented, which can have impact on how people behave. Next. So as I said, this work is in progress. We work with citizens to prioritize topics for recommendations, because as you can imagine, 4,000 recommendations, this is a fairly complicated process to make sure that we are not distorting information. So we have a large team of 25 people working on this particular project. The information is checked by citizens, so by lay people, by medical editors. We are now translating into 13 languages. Next. And this information is presented in different ways as compared to how it is presented by the guideline developers. So here are 3 different languages. As you can see, the information includes the actual recommendation, and this is some work that still needs to be modified with some translations. As I said, this is our current project, and what the information includes for people is first of all, why, for instance, a recommendation is issued, to whom it applies in different ways, and the underlying evidence, the description of the benefits and harms. Next. We are working on our Italian versions with some formatting changes that will still have to be taking place. This is a recommendation that was published in November that we are now working on. So this is related to home oxygen monitoring in symptomatic people with risk factors. Again, information about whom it is for. And next. And So information, for instance, as I already mentioned, why a recommendation may not be strong and why persuasion may not be the right approach here, but information might be the right approach. It's describing benefits and harms and any additional information that is required. But to also close the loop to what Dr. Magrini said in the very beginning, trials can be done in many different or for many different topics. So the question is if we are doing this right. Next. So what we are currently doing is doing a randomized trial that is informed by several phases of qualitative work that will help us to see if these presentation formats are actually appropriate. So we are targeting 3 different groups: adults, parents and caregivers, and adolescents, to see whether or not we can improve the way that we are currently presenting information, that organizations are presenting information in recommendations. This is being co-developed with citizens, so we do qualitative work in order to inform both the priorities, but also the way that the information is presented through workshops. And there's pilot testing of these versions to finalize templates that we can then test in actual randomized experiments to reduce some of the bias that might otherwise arise. So, finally, we're working with some, as I said, 3 different target conditions. It's only being done in English for the time being, but with international participation for those who actually are fluent in English. And we are testing, in this case, understanding, accessibility, satisfaction, and preferences for the type of formatting that we are presenting in these recommendations. And next, just very quickly an overview of the trial design, because I felt it was important to actually talk about trials that can be done in difficult conditions. And I certainly think this is not a simple condition. So this is where we're randomizing people to the standard versions or the plain language recommendations, and how we are then looking at 3 different groups. And I think it's particularly important to communicate with adolescents. We have users of the RecMap from over 160 countries, and what we see through the various analytics is that many of the users are actually younger than 25 years. And finally, next, this also serves as a model. Next, we have worked with the Canadian Agency for Drugs and Technology and Health. Next. On using this recommendation mapping, not with the PLR versions yet, but hopefully in the future, and the Global TB Department at WHO presenting information in this way to make sure that those who make decisions actually understand it and have the background information that is necessary. Next. And this is how you can contact us. I want to particularly acknowledge one of my colleagues, Tamara Lotfi, who is the coordinator for these projects. But as I said, and as I showed on the one slide, there's many different collaborators from across the globe, from many organizations, and we are both grateful and very happy that we actually had the possibility of working with so many wonderful people. Thank you very much.
Thank you very much. Nicola?
It has been a great pleasure. Waiting for some other questions. As you mentioned, educational activities, even at school level, and I know you're also involved in this Informed Choices project with other colleagues such as Ian Chalmers and so forth. What suggestions do you have? When to start at school? What's the format of these courses or lessons or whatever, to have an idea of feasibility?
Was that to me or to Holger?
To you, I think, Andy.
Both.
We started out working in primary schools, and some colleagues actually wanted to start earlier in kindergarten. And the reason for doing that is children are in school to learn. That's the time. Adults aren't looking for education or how to critically think. They're looking for answers to specific questions. And they don't have time, and they have to unlearn some concepts that they have in their head, whereas children are eager and enthusiastic. What we tested initially was a comic book textbook that worked very well. It's been translated to Italian and pilot tested there and has worked well in Italy as well. We're currently developing digital resources. A challenge with the book is it costs money to print books, and schools have limited budgets, especially in low-income countries. And so what we're working on now are digital resources targeted at lower secondary schools. But I think this teaching students, kids to think critically about claims about what they should or shouldn't do for their health is critical. The biggest challenge is getting it into the curriculum, where you again have to then struggle with adults who aren't as quick to see the importance, and there's all sorts of demands on the curriculum. So that's where the challenge is there.
Thank you.
Holger, may I ask you some more details about the trial you mentioned?
Sure.
So you compare the level of understanding in groups of citizens reading plain language with respect to another group reading recommendation in a standard language.
That is one of the outcomes. If the modification into plain language is better understood. We also including intended behavior as an outcome. But yes, that's essentially that first trial that we're conducting in these 3 different populations. Yeah,
that's very interesting. Very nice idea.
Yeah, the issue is just briefly, and by the way, I should have specifically, given that I'm speaking from Italy, specifically acknowledged my wonderful colleagues in Italy, in Rome in particular, at the Dipartimento di Epidemiologia at the ASL Lazio. So thanks for that. You are going to be responsible for all these translations that we are doing into Italian, and have collaborated in other words. But anyways, I think we really want to start testing again, not only here, but in the context of other guidelines as well, how to better communicate with the public. And there is work being done. There's not a lot of trials, and I think there's still a lot of work really that needs to be done to explore what features and elements of a recommendation really will be helpful. And I think this is where there's some synergy with what Andy presented, how to communicate with the public these criteria. So both the cube as well as the principles are obviously critical in this, but it needs to be tested, right? That was one of your criteria, and one of the principles. It needs to be tested, and that includes what is the general categories, what is the general domain that we should be communicating. Yeah.
And are you going to perform the trial in different countries and to compare also the outcome between different countries, or?
So for now, the trial is only going to be taking place in English. But I think the big benefit of these international networks is that there are many groups in different countries, and what we do is we make our trial protocols available through our executive team, which includes some 30 people that meets on a weekly basis, to utilize those protocols and apply for funding in other jurisdictions, because we have a certain. It's really a funding issue. We have funding from the Canadian government for a certain amount of work that we can do, but our trial protocols will be available to those who want to do that in other languages, and then obviously we can compare.
Thank you.
As we are not receiving many questions, or at least I don't see them, Holger, may I ask you a broad and general question on, you've been methodologist and sometimes coordinator of difficult guidelines. I remember to the audience the tuberculosis guideline for WHO, quite rigorous and complex, and the antithrombotic therapy, probably a monument in terms of guidelines that for many years has been a reference on a very complex topic. What's your view on handling these big tools, fairly big and absolutely rigorous? What could be the problem at local level when these big giant arrive, or what's the perception? What's your feeling at the end?
Yeah, I would again think that first of all, there needs to be efficiency, if that's what you're asking for, in the production of these guidelines and recommendations, and what that means is that I think at a country level, when we make these global recommendations, there needs to be efforts that focus on implementation, that include participation of the local, let's say, groups who are responsible for implementation. But at the same time, these big efforts, I think, can only support adaptation. My sense is that there's no implementation without a form of adaptation. We can talk about what that adaptation means, because just putting these recommendations out there doesn't mean that they are used, and that they're even accepted. That's a step before that they are accepted, and there's quite a bit of qualitative work at least indicating this, and it's about using the right strategies for these international guidelines to then implement and contextualize them. So if your question related to that I think is the big hurdle that we are facing in order to make these bigger international efforts actually useful for the globe, when they're intended for the globe.
You are inspiring me on the next title for our next seminar, so you're at risk of being invited a second time.
I think it would be a pleasure. Yeah, but of course, anytime, and thanks again for the invite.
So time is probably forcing us, or yeah. So I still wait a few seconds if nothing turns out from the public. I'm really very grateful to the speakers and to the many attending. It has been the best 2 hours of the week for me, and for sure. But even in normal times, probably would have been so. I hope that for you all, this attention to these complex and intertwined topics, so well treated by our guest speakers, have suggested you a more open dimension of thinking, feeling part of an international community, and the idea of always being part of an international research community has probably been the great lesson of Alessandro, and today our guests have testified this. Thanks again, Andy. Thanks again, Holger. Grazie, Patrizia. And
thank you very much.
A bientôt to all.
Grazie.
Okay.
The next
Ciao.
conference.
Next conference soon.
Bye-bye.
Okay. Bye.